Okay, so hello everyone. Let's go ahead and get started. So today's the second part of the multi-modality lectures on cardiomyopathies. And for this today's session, I'm going to start off with some data on CMR, and then Dr. Al-Mallah will talk to us about the role of nuclear-based techniques in cardiomyopathies. So last week, I think we talked about CMR for genetic and dilated cardiomyopathies, and what I'm going to focus on today is CMR for inflammatory and infiltrative restrictive cardiomyopathies. So let's start off with a case. This is a 44-year-old woman who has a past, or has really no past medical history. She came to the ER with 2 episodes of syncope within the last week. She reports tiredness, weakness for about 6 months, and has been experiencing some shortness of breath over the last few weeks. Denies any chest pain, orthopnea, P&D, or palpitations. Her blood pressure is stable, but her heart rate's a bit low, and normal physical exam. Here's her 12-lead electrocardiogram. Anyone want to tell me what they see here? One of the first-year fellows. Are there any first-year fellows here? Was that? Yes, Chachanushi. Very good. So this person's got complete heart block. So you've got a young person who comes in with syncopal episodes and complete heart block. So obviously one of the things you think about is, okay, this person may need pacing support, but it's important also, obviously, in a patient like this, to try to understand why is there this complete heart block in a relatively young person. So they did a series of lab tests, which were pretty unremarkable. An echocardiogram was done, which also was unremarkable, and then was referred for CMR really to assess the myocardium. So when you look at the cine MRI images, any observations that folks notice? Why don't we, Tanushree, since we've got you here, what do you see on the cine images? So these are short axis views and these are long axis views. And tell me what you see. Okay, so there's increased wall thickness, right? I mean, which is here in the basal septum, right? Okay, what else? On this view, it's probably, look at the long axis view. Yeah, so RV function I think is probably okay, but what else do you notice? What about RV wall thickness? There's a kind of a focal area of increased wall thickness. And then what about on this long axis view, even the lateral wall, right? There's an area of increased wall thickness, right? So clearly you've got some structural abnormalities that we can see here. Obviously, CT imaging is not the only thing that we would do. Really the most powerful thing you get by CMR is this tissue characterization with late gadolinium enhancement. And that's the bottom panel over here. So what do you see on these images? And again, this is done about 10 minutes after administration of gadolinium contrast, and we've picked an inversion time such that normal myocardium is nulled. And what do you see? You see areas, and interestingly, it corresponds to the areas where you saw increased wall thickness, right? You actually see hyperenhancement in the septum, in the lateral wall, and in fact, even in this basal RV free wall as well. You see areas of late gadolinium enhancement. And I've got the arrows there to make it even easier to tell. The other thing that you can do in a case like this, because the question is when you see hyperenhancement, as I talked about last week, what that tells you is that there's an increase in extracellular space. Doesn't tell you if this is collagen replacement scar, fibrosis, or if this is acute inflammation or acute myocardial injury. And so that's where the role of T2 weighted imaging is helpful, because on T2 weighted imaging, areas that are acute would show increased signal because there's an increase in water content, whereas areas that are chronic would not show this increase in T2 signal. And I think you can appreciate here in those areas that we saw a focal increase in wall thickness are also areas where you see actually an increase in T2 signal, which suggests that this hyperenhancement that we're seeing is in fact acute, not due to chronic scar. And then lastly, in every study that we do, we always want to take a look at the entire chest. And what do you notice? Maybe any of the fellows that are doing CT imaging. What do you notice on these images here? Anything that strikes out at you? What was that? Yeah, so is it a lung mass or is it more fullness in the hilar area that you can see here? And then also if you come up to the mediastinal or the paratracheal area, you see these areas of fullness, right? This is what you'd be concerned about is adenopathy. So if you put all of this together now, you've got a young person in their 40s who comes in with complete heart block, who has the cine as well as late gadolinium enhancement MRI findings. This would really raise the suspicion for an infiltrative cardiomyopathy like sarcoid. And so, in fact, this person did go on to get a biopsy done where they biopsied specifically in the LV at the site of the abnormality, and it was confirmed that the findings are consistent with cardiac sarcoid. So there's several studies that have looked at this. This was one of the first ones, which is about 10 years old now, which looked at a series of patients with known extracardiac sarcoid and used CMR to identify the presence of myocardial damage, basically late gadolinium enhancement. And what they found, several interesting findings. One is obviously that the patterns of hyperenhancement that you can see are quite variable. It can be subendocardial, it can be transmural, mid-myocardial, it can affect the RV, there can be multiple patchy foci that are present. And also what they found is that compared to the traditional Japanese Ministry of Health criteria to diagnose cardiac involvement, by CMR, they found evidence of hyperenhancement much more often, suggesting cardiac sarcoid may be more prevalent than we would have traditionally thought, or we traditionally be able to diagnose by the Japanese Ministry of Health criteria. And furthermore, what they found is if you looked at these patients with known extracardiac sarcoid, if there was no evidence of LGE in the myocardium, their event rate as far as arrhythmic events or bradycardic or tachycardic arrhythmic events or death was actually very good, whereas those who had evidence of cardiac involvement by CMR had a much worse prognosis. And then these findings were also confirmed in a meta-analysis which looked at a series of studies, I think 10 studies altogether, involving about 760 patients, which again found that the annual rates of cardiac events in patients who have known extracardiac sarcoid is very low if there's no evidence of cardiac involvement by late gadolinium enhancement, but is quite high in those patients who have evidence of cardiac involvement by CMR. And so really I think it brings us back to, in the clinical setting, how is it that we're going to interface with cardiac sarcoid in the MRI lab? And I think there's two pathways. One is in those patients who have known extracardiac sarcoid, where they're getting referred for imaging to try to find cardiac involvement. But the other is frequently in patients who don't have even a suspicion or known cardiac sarcoid or even sarcoidosis extracardiac, but who present with either unexplained heart block under the age of 60, with VT of unknown origin, or who present with new onset heart failure, where in this case, imaging by cardiac MRI can help you to identify the presence of cardiac abnormalities and to raise the suspicion for cardiac sarcoid as the underlying disease process. Now, let me show you this meta-analysis which just came out in the last few weeks in the Journal of American Heart Association, where they looked at a series of publications that have been published where there was actually autopsy images of patients with cardiac sarcoid. And they went through and looked at the images and characterized the location of the abnormality. And there's several interesting findings that they noted. One is that there were certain features that were present in over 90% of cases of cardiac sarcoid detected by autopsy. One was that there was LV subepicardial involvement, that there was multifocal involvement, that there was generally septal involvement, and that the RV free wall was frequently involved as well. So again, now there's a selection bias here because these are patients who died with cardiac sarcoid. So there may be a spectrum effect, but I think clearly these are the things that you'd want to look for with certainly advanced sarcoid. And some of the findings that they found to be rare in patients with autopsy-proven cardiac sarcoid was obviously one, the absence of any gross myocardial involvement, the absence of, or the presence of just isolated LV mid-myocardial involvement, which was not really very commonly seen in sarcoid, isolated LV subendocardial involvement, or isolated transmural involvement. So the idea being that this is really a disease process which oftentimes affects multiple regions, and it affects not just the LV, but also will affect the RV as well. Now let's move on to another inflammatory condition, one that we may not see that often, but this is systemic lupus. And this was a nice publication from a European group where they looked at a series of patients with systemic lupus as well as a series of controls. And what they found was that in patients with systemic lupus, there was a fairly high prevalence of having areas of myocardial late gadolinium enhancement. They found in their series about 61% of the patients had evidence of some LGE somewhere in the myocardium. And it varied. Sometimes it was epicardial, sometimes it was mid-myocardial, and sometimes it involved the insertion site where the RV connects to the interventricular septum. They also found, interestingly, that pericardial hyperenhancement was present in a reasonable number of these patients as well, as is shown in the bottom image on the right-hand side here. And so these are some of the findings that you would think about if you're looking for cardiac involvement in patients with known systemic lupus. Now, let me turn now to the infiltrative or restrictive cardiomyopathies. And here's a patient who, when we look at the cine MRI images, we see several interesting features. One is there's a small pericardial effusion, which again you can see is the area of high signal around the left ventricular myocardium. There's increased wall thickness, about 1.6 centimeters. The RV in this case is also increased thickness at about 0.8 centimeters. There's biatrial enlargement, as you can see on the 4-chamber view in the bottom panel. The LVEF is mildly reduced in this case, as is the RVEF, and the overall LV mass is significantly increased. But I think just by this, there could be a variety of different things that could be in our differential when we see these findings. When we couple this with our late gadolinium enhancement MRI, you'll notice a pattern with diffuse LV as well as RV involvement, with diffuse atrial involvement as well. And again, you can see that very nicely on the 4-chamber and the 3-chamber views at the bottom panel. Papillary muscle hyperenhancement as well. Let me see if I can get the pointer to show this. You can see right here the papillary muscle show hyperenhancement as well. And then these are findings that are typical of what you would think about for amyloid heart disease. There's several studies, single center as well as multi-center, which have shown that if you have patients with known extracardiac amyloidosis, then use of CMR and late gadolinium enhancement can help you identify the presence of cardiac involvement. And in this single center study, which came out about 10 years ago, those patients who had extracardiac amyloidosis but no evidence of hyperenhancement in the myocardium by CMR had a very good prognosis, but those who had evidence of any hyperenhancement had a much worse prognosis. And in fact, the presence or absence of LGE was a better discriminator than New York Heart Association class was in these patients. And then more recently, we were involved in a multi-center study which looked to confirm these findings in a multi-center fashion. And again, for patients that presented with known extracardiac amyloidosis, the absence of hyperenhancement was associated with a much better prognosis than the presence of any hyperenhancement within the myocardium. Now, one of the things that I think always comes up is, so how is it that you see hyperenhancement in the setting of amyloid heart disease? And it goes back to, I think, what I was talking about last week, which is that the kinetics of gadolinium are such that gadolinium will concentrate in any areas where there's an increase in extracellular space. So obviously, that happens in the setting of an acute MI, where you have myocyte rupture and the extracellular space increases. Happens in the setting of chronic MI or chronic scar from non-ischemic etiologies, where you've got now a lot of extracellular space between the collagen matrix. But it can also happen in the setting of amyloid heart disease as well, where you've got this protein deposition between myocytes, and as a result, this leads to an increase in extracellular space. And essentially, that's what we're imaging when we image by MRI. And It's also important that not only late gadolinium enhancement findings, but there's other findings that can also be useful from a prognostic standpoint. And this is some data that came out just last year from a group out in England, where they looked at other features such as tricuspid annular plane excursion, or TAPSE, as well as simply looking at the stroke volume index. And an LV stroke volume index of less than 42 identified a group of patients with amyloidosis that were at high risk for subsequent cardiovascular events. An important thing I think, though, to keep in mind is that some of the classic images that we saw of a cardiac amyloidosis were ones where there was extensive diffuse hyperenhancement, but really there may be a spectrum here, and this is one case that we had recently, obviously, where the amount of hyperenhancement is really not that striking. There's some patchy areas of hyperenhancement that you see in the septum as well as the lateral wall. And this person, though, was actually biopsy confirmed to have evidence of cardiac amyloidosis. And so again, maybe this is a patient that we're picking up very early in the disease process. But I think it's always important to kind of keep in the back of your mind that the classic findings that you see in the more advanced stages may not be necessarily what you see in the very early stages of disease. Another thing that always comes up is, well, can you do anything with non-contrast imaging in those patients that you can't give gadolinium contrast? So this was, again, some data from the group in England that came out just earlier this year, where they actually went through and looked at native T1 times, and they found in their cohort of patients, which I think this was a couple hundred patients here, that native T1 times of, in this case, less than 1036 milliseconds almost never was associated with cardiac amyloid involvement. And then native T1 times that were very high, and again, this is for a 1.5 Tesla scanner, greater than 1164, was almost always associated with the presence of cardiac amyloid infiltration. And then for those times in the middle, you'd obviously want to give gadolinium contrast to further refine your assessment. So again, a few things with native T1 time, obviously, is that can be scanner dependent. It can be field strength dependent. So if you're doing it at 1.5 Tesla versus 3 Tesla, T1 values are different. And so that's where they proposed looking at Z-scores based on kind of what the range of values are for normals within that particular scanner. So again, I would say this is not something that's, we would begin to implement immediately. But I think this is at least one of the things to keep in mind, as in the future, I think it may hold that we may be able to get an assessment just with native T1 times without having to use gadolinium contrast. So let's move to another case. This is a 29-year-old African-American woman who presents with pneumonia and retrosternal chest pain. She has a small cardiac enzyme release, and here's her cine MRI images shown here. So we've called on Chanushri a few times, so let's call on somebody else. Tell me what you see. One of the second-year fellows? Peter?
Sure. So there's LV wall.
Okay, let me play this again. I'm not sure why it stopped. Whoops. Okay.
So there's LV that's asymmetric.
Okay.
It's more anterior.
Right. So it looks like it's more anterior, right? So one is regional. And again, you always want to be careful because hypertrophy would suggest that there's myocyte hypertrophy. All we can tell here, there's increased wall thickness, right? It could be from the myocytes hypertrophying versus it could be in amyloid, for example. It may not actually be myocyte hypertrophy, but rather protein deposition. So what you see here is that there's regional increase in wall thickness, right? And it's predominantly in the anterior wall. And what about contractility? How did contractility look? Whoops, it already... Let's see. All right. You think contractility is reduced? Yeah, if it is, it's like 55 to 59. So really not a significant impairment in LV contractility. And again, though, this is where I think the ability to not just look at the myocardium, but to probe the myocardial tissue composition is crucial. If you look at the bottom panel here, this is our late gadolinium enhancement. And what do you notice? Several interesting findings. One is you've got these areas of black here, right? And you've got an area of high signal that's here. and then you've got the normal myocardium that's here. It's kind of like this three-layer appearance that you're seeing. So this is one of those things it's almost a pattern recognition. Whenever you see this, you have to say, wait a second, this is not normally what you would see with just LV hypertrophy. This, in fact, there's different tissue composition that's present here. There's actually a layer of normal myocardium, and then this is a layer that's inflamed, as well as probably has some thrombosis within it. And this person, when you do the lab test, white blood cell count is 20,000 with a very high eosinophil predominance. And so this is an example of idiopathic hypersinophilic or eosinophilic syndrome, which leads to eosinophilic myocarditis, or oftentimes we use the terminology Loeffler's. This is important to identify because how do you treat this? Well, this person actually was treated with 3 months of high-dose steroids and anticoagulation, and you can see here now the wall thickness, the increased wall thickness is gone. So you've now had almost complete resolution back to the normal state. So again, I think the ability to probe the tissues is what allows you to get a much better assessment. Okay, so let's keep going. Let's look at another condition, and this is siderosis. So obviously we know that iron overload, the hallmark of this is going to be the liver. So it always is going to affect the liver first, but then you can have scenarios where there's a discordance. You can have a case where the liver could be affected, but the heart may not be affected, or you could have a case where the liver is affected and the heart is affected as well. And so the techniques to assess iron content in the liver have been around for quite some time, but it was really in the late 1990s that a technique was developed called T2 star to actually be able to assess the iron content within the myocardium or the heart. And it's really now become a very robust technique, which literally can be done with a single 10-second breath hold, where you get a series of images at slightly different echo times, and from that you can actually map out what the T2 star decay is of the myocardial tissue. And obviously one of the things is that T2 star decay is accelerated in the presence of iron. So if there's iron overload within the myocardium, then your T2 star values are going to drop much, much faster. And so there's normal values that have been established as well, which is a normal T2 star value should be less than or greater than 20 milliseconds. And then less than 10 milliseconds is suggestive of severe iron overload. And then between 10 and 20 is kind of borderline. What's also interesting is using this technique, and most of this work was really done by Dudley Pinnell and his group out at the Royal Brompton, that they were able to actually track serial changes in patients that were getting iron chelation therapy. And what they found is that with iron chelation therapy, not only do you see a reduction, an increase in the myocardial T2 star time, but you also see improvement in LV functional parameters as well. But there are a few other findings that they noticed. One is that advanced siderosis cardiomyopathy can be reversed with iron chelation therapy, which then again will lead to an improvement in LV contractility. That myocardial T2 star times really improved in parallel with improvements in functional parameter. But I think very interestingly was that iron clearance from the liver is much faster than iron clearance from the heart. And that's where I think the strength of this technique is that if you've got a patient who has iron overload and you begin chelation therapy, you may extract all the iron out of the liver, so your liver T2 star values look normal. As we see here, the liver doesn't appear black, but the heart may still be iron overloaded. And so it's really being able to track the iron overload within the heart, which allows you to kind of further modify your chelation therapy. And I think one of probably the most exciting things is that the fact that using this technique to help kind of optimally treat these patients with thalassemia with chelation therapy really resulted, in fact, in a significant decrease in the incidence of iron overload death in the UK population. So again, showing that using imaging to be able to do optimal patient management can actually, in fact, result in improvement in outcomes. So let's look at another condition, and this is Anderson-Fabry disease, which again leads to infiltration within the myocardium. The classic finding that was described in Anderson-Fabry disease is this hyperenhancement that occurs in the infralateral wall of the left ventricle, as you can see in these examples here. And this was a publication from 2003. But the reality is, more recent studies have shown, in fact, that there can be a variety of patterns of hyperenhancement that, in addition to the LV being affected, you can oftentimes have patchy multiple foci, you can have septal involvement, you can have anterior lateral wall involvement. And so it's really a spectrum of phenotypes that can occur with Anderson-Fabry disease, so that in addition to increased wall thickness, you can really get various differing patterns of myocardial late gadolinium enhancement. I think one of the advantages now that we have not only the traditional late gadolinium enhancement, but we also have techniques where we can directly measure T1 times in the myocardium, is that with Anderson-Fabry disease, it tends to actually result in a lowering in T1 time because it's a fatty deposition. And as a result, this series right here showed very nicely that you could actually use T1 times to identify or to separate those with increased wall thickness that was due to Anderson-Fabry disease from those with increased wall thickness that were due to other conditions such as hypertension, hypertrophic cardiomyopathy, or severe aortic stenosis, or amyloid. But I think one of the things to keep in mind is that there's still overlap in T1 times between normal volunteers and patients with Anderson-Fabry disease. So again, where I think this can be useful is in the proper clinical setting. And somebody who has the hypertrophy, who you suspect has pathologic hypertrophy, where in those cases, if you see a very low T1 time, that could tip you off that this may be more of an Anderson-Fabry picture versus hypertrophic cardiomyopathy or amyloid or something else. And so I think what I want to wrap up with now is I think that really the way I think we're going to start approaching cardiomyopathies in the future is not just looking at the characteristic patterns of late gadolinium enhancement that I've shown you previously, but also coupling that with information with regard to native T1 time and extracellular volume fraction to really be able to try to further refine the diagnoses in these patients. So let me wrap up here by just saying that I think there's our CMR team. I think the final conclusions that I want to make, I think, is that the use of CMR, both cine imaging, which allows us to look at structure and function, but really late gadolinium enhancement, which allows us to look for myocardial tissue alteration, coupled with the newer T1 mapping techniques, I think, will give us a much more refined assessment of the myocardium in our patients. So thank you for your attention. And I'm going to turn it over to Dr. Al-Mallah, who's going to... Okay.
Can I show it also on this monitor here? Yeah, but it's not showing. Just gotta push this button here. Yeah, which button? Okay, that's fine. There you go. All right, so we'll continue where Dipan stopped, and as you know, now with healthcare technology, we have new tools, and obviously for every tool, we're gonna see where do they fit in the management of these patients. So I'm gonna focus on the role of nuclear cardiology techniques, which probably did not exist in the field of cardiomyopathy many years ago. In the past 10 years, there have been a wealth of literature and studies looking at where we can help in these patients. And I'll start with the case. This is a 65-year-old man who has been moving around from one practice to another in the medical center because of new onset heart failure, low ejection fraction. He has been having ventricular arrhythmias, had an ICD. According to the patient, had almost one day 16 shocks. had a complete heart block and required CRTD. All of that with normal angiogram, and you can see here his LV ejection fraction and RV, both of them are failing. You can see how much delayed enhancement he has on the MRI. Now the images are a little bit not what we are used to because this patient has a device and these are device, the images, the sequences are affected by the device. So you can see here there is significant scarring in this patient, and the question that came to us, can you tell us what type of scarring? This patient had a biopsy which came as non-specific fibrosis. So what we did is I was trying to see specifically if this patient has an inflammation. Is this scarring or this is an inflammatory process? So first of all, we have to do some preparation. And you see at the back our nurses and techs who called the patient the day before specifically to try to optimize the success of the procedure. Because to image the inflammation in the heart, we need to suppress the myocardial FTG uptake. And we want primarily to image the white blood cells or macrophages that are invading the heart. So we follow this protocol in our practice where we tell them they need to be fasting for more than 12 hours. We want zero carbohydrate diet for more than 24 hours. And when they came to us, we give them 50 units of heparin about 15 minutes prior to injection of our FTG. And then we go ahead and image them, hoping that only the white blood cells, if it is an inflammatory process, only the white blood cells will uptake the FTG, and the myocardium will have enough free fatty acid to uptake it. So at least the guidelines, if you look at it, this is what's recommended. You want at least 2 high fat, more than 35 gram, and low carbohydrate, which is less than 3 grams, meals the day before. So once we open this to the door for inpatients, we want to make sure that don't call us in the same day and say, I want this, because these patients need to be well prepared to be able to do these studies. So I guess in Houston, this is what we offer them here. And if a normal study would look like this, all the FTG will not be taken by the myocardium. So you see, it's like all the FTG stays in the blood pool, and the myocardium has no uptake. So we see more of a blood pool kind of image or a negative image in there. And if we look at it in short axis, now you can see that there's no uptake in the myocardium and all the FTG is in the blood pools. This is what we call a negative study, normal perfusion and no FTG uptake by the myocardium. And you can see here, we see the LV, we see the muscle there, but no uptake neither in the RV nor in the LV. So this is our patient. And you can see here, he does not look normal, obviously. So there is a perfusion defect. So what we do is that we do perfusion to see if there is a perfusion defect, very similar to what we do with our regular nuclear studies on Fundrin 9 for perfusion. But then we look at the metabolism, and you can see in these areas where there is perfusion defect, now there is FTG uptake, which tells you that this area, based on the preparation, we know that we suppress the myocardium. So this is not the myocardium that's uptaking that. It is actually the inflammatory cells that are sitting there and are uptaking that. So you kind of see what we call like a mirror image. So whatever is missing on the first row is complemented by what we see here. And for example, here you can see the septum is short and it's completed here. The basal septum has uptake in here. Similarly, we see in the anterior wall, there is a small perfusion defect here, and there is significant uptake in the same area. So if you remember from the very first images I showed you, these are the very same areas that had a lot of late gadolinium enhancement. So this is clearly a patient who has been having a lot of inflammation in his heart. Now, can I tell what type of inflammation is this? It's difficult to us to go more phenotypically beyond that. So our reports will say inflammatory cardiomyopathy, sarcoid could be it, but it also could be lupus. All the other inflammatory cardiomyopathies that Dipan just mentioned will be can give you a very similar picture. And this patient also very interestingly, so here you see the uptake in the septum, you see it in the lateral wall, but we also saw it in the left atrium. And this patient actually was having some of these ICD shocks I told you about were actually inappropriate ICD shocks because of atrial tachycardia and other atrial arrhythmias. So you can see here that there is this atrial FTG uptake, and you can see it also in other views, which is probably only seen in very advanced diseases like this patient. So if you look at it again, we can look in different ways and different colors, and you can appreciate it. This is the hallmark of cardiac PET in sarcoidosis, where we see a perfusion defect where there is FDG uptake after you follow the appropriate preparation. And there have been a lot of data in patients who had both tests. How complementary is it for MRI? I showed you just one case, and this is another case I had before where there is delayed enhancement here, there is a perfusion defect in the anterior wall, and there is FTG uptake in the same territory. However, it's not always one-to-one, so this is only in the acute phase, and here you get a sense kind of like the delayed enhancement is not as bright, which tells you it's a little bit more of a edematous tissue, and this is where probably it is adding to the diagnosis. But with PET, we also can diagnose extracardiac sarcoid. So this is one of our patients here who had no cardiac uptake at all. But you can see how intense of an uptake we saw in his lung, and he had scarring and infiltrate, and this patient had a biopsy-proven sarcoidosis in his lungs. So we can diagnose cardiac, but we can also look at anything within our field of view. Our machine has a field of view of 26 centimeters, so this is not the usual kind of coverage for other PET scanners, but this allows you to be able to see more often than what we usually see in other scanners. We can also see some RV uptake in here. So this is a patient who has an RV late gadolinium enhancement, and if you look in here, there's a faint faint FTG uptake that you see in the RV. And this is not very common, not easily identified because the amount of tissue that you have in there is not too much compared to the LV, so it can be easily suppressed by how much we see in there. And this is another case from the literature with extracardiac sarcoid, as we've seen before. So when we read them, it's not as straightforward as it may appear. So the first one is that we call it normal, completely normal, when we see normal perfusion, no perfusion defect, and no FTG uptake. That's clearly normal. Unfortunately, there is a small percent of patients, and in the Brigham group, 12% of their patients, despite having a fully normal perfusion, there is also diffuse focal disease, diffuse disease in there. And they think this is just because they could not suppress the myocardium very well. Here we have had one patient like this out of the 40 plus patients that we've done so far. And this is one patient where you see normal perfusion on the top. We did the delayed enhancement, and honestly, his pretest likelihood was not that high to start with. So I went ahead, and when we looked at it, there is so much FTG uptake, way out of proportion to the patient, what we should clinically expect. So I brought the patient back, emphasized that he follows the diet. We want to make sure that we get the appropriate study. And he clearly told us that he did follow the diet. And despite that, you can clearly see that we're still unable to suppress the myocardium. So this is one case where we technically failed to suppress the myocardium. I don't know why, but this is a patient that we could not make the diagnosis. I wouldn't call all of this as inflammation. Now, how are we calling? Sometimes we have abnormal perfusion or metabolism. So one area where FTG PET alone can be false positive is in the basal inferolateral. For unknown reasons, in the absence of perfusion defect, people have been concerned either this is either early disease. So if this is the only area that we can see FTG uptake, then we should raise the possibility of being false positive. And then sometimes you can have a rest perfusion defect, as you've seen there but there is no FTG uptake. And these are patients who already had cardiac sarcoidosis or scar from any other disease, and now there is no FTG uptake in that territory. And the positive patterns I've already shown you, it's kind of most of them are just the most important one is the mirror image one, where there is a perfusion defect, and now you fill it up with FTG. It has prognostic value, as you've seen with MRI. So the FTG uptake, the more FTG uptake you see, the worse outcome for these patients. And now we can go ahead and follow it up for therapy by PET and potentially MRI. I'll show you also a case that came to us. Patient walked into the emergency room with chest pain and palpitations, had a VT arrest in the emergency room or VF arrest. They shocked him, admitted him, extensive workup. Eventually, she had a normal LV function overall, or like low normal, but then he had normal coronaries also. And they did an MRI, and the MRI clearly shows some scarring in there, diffuse, patchy, non-coronary pattern. You can see it in different areas in the anterolateral wall and in the inferolateral wall here. So he was referred to us to do a cardiac PET on him. And you can see here the same areas that has a delayed enhancement has FTG uptake. And in this patient, you also see some RV uptake, which we see a hint of it here also. I put it in black and white because it's easier to see the RV in the black and white. So this patient actually, you can see also this area in the basal septum, and he has significant RV uptake in there, and the inferolateral wall. And this scan, for some reason, it's not as evident, but you can see it here that there is significant FTG uptake in the inferolateral wall. So we called him positive for inflammatory cardiomyopathy. We referred him to our expert here, and she put him on the therapies that are needed, steroids and Celcept. And 3 months later, now I don't see any FTG uptake in there. So you see the myocardium, it's all gone. Now you still see a minor perfusion defect, but the small scar that you see, you might not be able to detect by nuclear compared to MRI. And this is the patient you can see here. This is before in color. He has normal perfusion. He has this delayed, his FTG uptake in the inferior wall. 3 months after therapy, all the FTG uptake is gone from the myocardium. And this patient, we call it, I told Mouaz, I'm going to call it the Cassie effect, because she's the one who's been following these patients.
We're sorry. Your conference is ending now. Please hang up.
All right, you're dismissed. All right. So you can see here, I can show you the impact of therapy on different ways. So here, like with fusion imaging, you can see the uptake here. You can see the uptake in the walls. And now there is no uptake in the myocardium, just a blood pool effect where there is FTG. 3 months of high-dose steroids and Celcept. Now, this patient, we brought him back and had an MRI now, and you can see the same areas that had a delayed enhancement, specifically the inferior wall, infralateral wall, still has the delayed enhancement there. So his delayed enhancement have decreased a little bit, but it's still there. You can see other areas. Now the image quality may not be as good because now he has a device after the event, but you can see the different areas, including the papillary muscle. So this is his MRI before, and this is his current MRI. He still have something in the RV in there. So technically what we can see from this is that with FTG, with sarcoid, with PET, we are able to detect the disease activity. And now with MRI, we're determining whether the patient had any flare-up of the disease or involvement of the heart at any point in his disease progression. So where do you fit it together? So if someone has a normal CMR, technically, the negative predictive value of CMR is going to be very high, unless you're suspecting active early disease. So someone has a normal CMR, it's extremely unlikely that they will have a positive PET, unless the patient is and have very high level of suspicion, or the only situation where it could be the other thing is in patients who have just isolated AV block where it's only involving the AV node, which may be a problem for CMR sometimes if it is so small and at the annulus level. Now, if it is in these patients, if they have negative CMR, unless you have a high likelihood or high suspicion, you don't need to proceed. Now, if you find this delayed enhancement or scarring on MRI, then you probably need to know if this is active disease or this is disease that happened sometime in the past. And this is where PET adds a lot of information there because it will help you help guide you in terms of defining the therapy for this patient. Okay, and I was asked many times before about other inflammatory cardiomyopathies and myocarditis. So there's not much in the literature about viral myocarditis, although there was this abstract presented 3 years ago. I searched for it this morning to see if it's ever been published as a paper. And they looked at 395 patients who had prevalence of myocarditis by ESC criteria by 75%, and nearly 164 of them had a positive PET. And they're reporting that the PET accuracy sensitivity was 52%, but specificity 88%. Now we're still waiting for the paper to see the full details of this is data just from the abstract, and we need to know more about what type of myocarditis. Are these just viral, or some of it is connective tissue disease related, or others? Okay, so let's switch now to the infiltrative or restrictive cardiomyopathies, and this is an area where nuclear cardiology had no interference with in the past many years until very recently, when some of the clinical applications of PYP imaging started to emerge. And we had few discussions about that in the recent weeks, but I'll just summarize. You know now that we are seeing an increase in the number of cases of amyloidosis. This is not because of an epidemic going, probably more of a better diagnostic ability to diagnose these patients using CMR and other tools, EchoStrain and PYP imaging. So this is a patient that I've seen before, and you've just seen some cases with Dipan. Looking at patients with restrictive cardiomyopathies, you can see the annular. This is a very stiff heart with every valve leaking, and the patient has significant shortness of breath. You're unable to null the myocardium in this patient, and this is now the hallmark of what we call an MRI diffuse delayed enhancement or late gadolinium enhancement, and this is for amyloidosis. Now, because the management amyloidosis is not one disease, but there we have, as you know, the AL and the ATTR types. And the different types have different management in terms of completely different management plans. And it's very important to make the distinction. And most often prior to PYP era, we've been sending these to biopsy or other testing to identify whether they had AL versus ATTR. Now we have some tools that allow us to be able to determine if they are AL or ATTR by PYP imaging, which lights up significantly in ATTR and has no uptake at all in AL. Now, this is only specifically to patients who have high clinical suspicion and have other imaging modalities that suggested that these patients may have AL or amyloidosis. The history for this goes back to many years. Tanushi showed us prior studies that looked at this before the era of AL versus ATTR distinction, where PYP scans failed significantly. When they looked at it, when they looked at familial amyloidotic polyneuropathy, they had better luck in there, where there was significant higher uptake in the heart among the patients who had familial pattern. This is specifically a bone scan. So technically what we are doing here is similar to bone scan. So who are the patients you cannot send them to the bone scan? Very little contraindications unless the patient is really claustrophobic. SPECT machines are not that bad in terms of claustrophobia. The patient is gonna lie on their back for a good 30 minutes. They need to have obviously an IV, and unless they have allergy to PYP, which is, I personally have not seen it. Everybody can potentially get it. So how we diagnose it, how we make the assessment of the images, very simple. So we are doing planar imaging. So planar imaging, for those of us who did not practice many years ago, think of it like a chest x-ray. So nuclear cardiology, but just like a chest x-ray. So you don't know where the uptake is coming from. So you put the camera in front of the patient and you're just acquiring these counts. And since this is a bone scan, people have come up with some subjective criteria. So if there is no uptake, you just call it grade 0. If the uptake, there is some uptake, but it's less than the ribs, then you call it 1. If the uptake is equal to the ribs, now it's 2. If the uptake is more than the ribs, it's grade 3. So very subjective. We can argue from now till tomorrow which one is more than the ribs or less than the ribs, but technically people wanted to come up with some objective criteria. And how we do it, so people suggested, why don't we just draw a region of interest? We draw one over the heart and one over the contralateral lung. And somebody could ask me why they chose the contralateral lung. It's most often in the field of view. They don't want to go to the brain or the abdomen. So this is kind of a, just like how it was done from the beginning, and that's why how we try to do it today. And they found out that if the ratio is more than 1.5, it was very sensitive, very specific for ATTR amyloidosis. Now, there are some pitfalls, obviously, that you need to be aware of. So if there is a breast implant in a lady here, obviously the counts are going to be less. Your ratio is going to be falsely high. If there is pleural effusion, if there is a pericardial effusion, the count on the heart is going to be less. So you have to think of it as a tool that this is not written in stone, that number that we're putting. It depends on how big also your circle is. So if your circle is very small, you're going to have some variability. However, if your circle is big and encompass most of the heart, then you're going to be able to be more accurate in there. And this is, for example, a patient where the heart is 67, the contralateral lung is 43, and then the ratio is 1.5. So really at the edge for this patient. But now, using this criteria, people have suggested that the accuracy among patients who have 2 to 3 grade specificity was 100%, and the positive predictive value was 100%. This is among patients who have a high pretest likelihood and were done like so very much suspected they had typical echo and MRI findings. And on top of that, they had a grade 2 or 3. Now, if you go to more real-life data, this is a meta-analysis of 6 studies, 529 patients. Sensitivity is about 92%. Specificity is very high, 95%. And as you know, the positive likelihood is 7. So it is really was going to make your probability of having ATTR amyloidosis very high. Now, there are some issues also in when do we image these patients? Is it early or late? And because some of those people who started the field were imaging at 3 hours, some of them were doing at 1 hour. So if you read in the literature, you find some papers are coming at 1 hour, some papers are at 3 hours. So this is a patient at 1 hour. You can see that there is uptake. It's more than the ribs, and the ratio was 1.61. They waited and imaged the patient again at 3 hours. Now the ratio is 1.39. And if you look at it on the spec, there was no cardiac uptake at 3 hours. So technically, it was all on the blood pool. Remember, many of these patients have heart failure. Their heart is not pumping very well, and the PYP stays in the blood pool for some time, and this might be another reason for false positive. This is also another patient that we have here where we did at 3 hours, and the ratio is 1.6. Now, we went ahead and did an additional step where we've done actually a SPECT. Now, think of SPECT. Now, we're moving from a chest X-ray to a CT of the chest. Now, I see where the counts are coming from. Now, this is easy if there is strong uptake because I can go and look for the heart. But if it is not that easy, if the uptake is a little bit faint. But this one looks like a regular nuclear scan where the PYP is specifically coming, the signal is coming from the myocardium. So you're pretty sure that this patient has the ATTR amyloid. Now, it's very important, as I said, the issue of bone uptake and to look at other sources why you may get positive and negative. So we're here, we're taking it a little bit more specific nowadays because we wanted to make sure that we are getting it from the heart. So we're doing all our cases on the SPECT CT, and now I'm fusing the SPECT and CT, and now I get images where I have the signal coming, I know exactly this is where the septum is normally. So I see the signal coming from the septum and from the inferolateral wall. So I'm pretty sure, although the the signal is not coming from the entire myocardium because of the patchiness of the disease, now I'm very confident that this is coming from the heart. And this is another patient where you can see at 1 hour there was a lot of uptake, but it's coming at 1.57. At 3 hours, the ratio is 1.5. When we did this, you can see that there is signals coming mostly from the basal anterior septum and basal inferolateral. So now I'm pretty sure that this is coming from the heart, although it's not involving the entire heart. The ratio is really at the cutoff, but I'm pretty sure that this signal is coming from the heart. And obviously, you have intense vertebral uptake because this is just a bone scan there. So I want to finish up with the potential false positives and negative because these might be problematic in the workup. So obviously AL amyloidosis can be false positive in about 3%. So we don't recommend you go to PYP until you've ruled it out by protein immunofixation or whatever other methodology needed. There have been some case reports, including a couple from our site here, looking at hydroxychloroquine toxicity, which might give you the same pattern as ATTR amyloid. If there is rib fracture, it depends on which side the rib fracture is. It might give you false positive or negative because if there is increased uptake in there. Pleural effusion, again, it depends on which side the effusion is. If there is a blood pooling, that's probably the most common cause of false positives. Breast implants, it depends on which side, and if you draw the ROI over the implant or away a little bit from it. If there is recent myocardial infarction and the inflammatory process might have some PYP uptake in there. And then there are some specific mutations that have been associated with false positives. Now, false negatives, early disease, if we waited too long until a lot of the counts have decayed, so no one has been waiting more than 3 hours. If there is only small dose that you injected, if the patient has short time of acquisition, we had one time the patient could not continue the image acquisition, and then if it is positive, great, but if negative, you cannot completely rule out the disease. And obviously pericardial effusion might give you false negative because you're drawing the ROI and the dose is kind of downplayed by the pericardial effusion. And if there are breast implants and specific types, the type B, these mutations give you false negative even in ATTR. So I think this is a technique that has to be done right, and it's very promising. There's significant learning curve, and hopefully one day we will have negate the need for biopsies for these patients whenever you have a dedicated testing and you have non-invasive biopsy for these patients. I think we're gonna stop and take some questions.
Your current protocol now is with the SPECT, so you don't do any routine planner anymore.
We're doing planar because we calculate the ratio only on the planar.
Okay,
You
so
cannot
you do
calculate
both.
the
You do a
ratio.
planner, and then you pass into the.
We're doing it at 1 hour, at 3 hours to decide
Got it.
eventually which one we're gonna drop it.
Now, is this something that other groups are also doing, or is this something that
So
we are
few sites
developing
are doing
here?
it. So Mayo Clinic also are doing it, and I think Mid-America Heart Institute. But most other sites are just doing the planar. If you're gonna do just a planar, you may run the risk of having a false positives.
So I have a question. By the way, the two lectures were fantastic. This was really an excellent session. Question for the two of you. Dipan, you show one slide at the end. What's, I think, the last slide where you had the circles. And the athlete's heart were a little bit off normals. And there's been a lot of interest lately on an athlete cardiomyopathy, whether people can overdo it with exercise and start having some myocardial injury and problems. Number one, that is way open field because it's sort of a new concept. Where do you see MRI helping and possibly even PET helping in this entity with so many people going crazy with exercise and doing marathons and triathlons and you name it?
No, so that's a very good question. I mean, I think that the slide that I showed was kind of a concept slide of what the ECV and T1 values
Right.
do with different disease states or different conditions. And there's not a lot of data on this. There is some data. There was one research letter in the European Heart Journal that looked at it in athletes, the ECVs, in kind of most athletes, the ECV values are actually lower than the normal values. And the reason is because they have mainly hypertrophy of the myocyte
Right.
without really a lot of extracellular
Of
space
extracellular,
expansion.
yeah.
Now, obviously, if you've got very extreme athletes, there's some data showing troponin release and all of that. And, for people that maybe do very, very strenuous activity, there may be some myocyte necrosis or some damage that occurs. But I don't think we really have a full handle on that.
And PET, is there any room for PET helping with looking more as, is there such an entity as an athlete cardiomyopathy?
Athlete heart, we haven't invaded that territory yet.
I mean, I
It's
think
an important area to study. I mean, we can look at myocardial perfusion from a perfusion standpoint and coronary flow reserve. I would suspect these patients will have a very low resting flow, but they have a very high flow reserve in their patients. But no, we haven't.
Yeah, and part of the problem, of course, is that probably the incidence is very low. I mean, most athletes are fine and they're healthy and they have great hearts. But every year somebody drops dead in one of these marathons. So although the frequency or the incidence is low, it's still kind of an enigmatic disease. I mean, we still don't even know. I mean, not even know if it's a disease, but there's an enigmatic condition as to. And I don't know if there's room for. We have our annual marathon here. I don't know if there's any room for looking into this.
Yeah, I mean, the thing is you need a very sensitive technique. I think that's the thing. And I think, even with CMR, your spatial resolution is about 1.5 millimeters. I don't know if it's going to pick up these very, very small little areas of necrosis.
Okay.